So is the severity of the stenosis indicated by the intensity of the murmur? Because if we say like if the murmur is more, the stenosis is more. Can you say that? No. You cannot determine the severity of the stenosis by the intensity of the murmur. You can assess the severity of the stenosis only by the clinical signs and the symptoms. Next slide, please. See, so here you can tell only by the the symptoms. So here you can see a slow rising pulse, narrow pulse pressure, long duration of the murmur, and the left ventricular heave and S4 sound will be heard, and there will be left ventricular hypertrophy. So you cannot determine the severity of the stenosis by the intensity of the murmur. So intensity of murmur has nothing to do with the stenosis. So this is how it happens. As I told you earlier, the narrowing of the aortic valve orifice leads to the restriction of flow from LV into the ascending area, ascending aorta. So from the LV, there won't be the problem. There will be because of the aortic stenosis, the blood will not be pumped into the aorta. So what happens? Obviously, the LV chamber pressure increases. So when the pressure increases, automatically the wall tension on the LV increases. So this leads to increase of the there will be hypertrophy of the left ventricle. So because there is a hypertrophy of the left ventricle, it leads to the ischemia and the arrhythmias. So this is the problem usually that occurs with the narrowing of the aortic wall. This is a classification as per the ESC guidelines. Just go through. This depends on the valve anatomy, valve hemodynamics, hemodynamic consequences and symptoms. You don't need to go all these things. It's just for your knowledge. I have just put this slide. You can actually go through when you are free. Okay, next. So what are the investigations we do? So for the aortic stenosis, the main thing for the aortic stenosis is actually the clinical judgment. On the chest X-ray, you don't see anything except the ascending aortic dilatation, and heart size will be usually normal, and chest X-ray will be normal. And as I told you earlier, in the late stages only, you will have a cardiac enlargement, or because of the because of the increase in the arterial pressures, you may have a pulmonary congestion because there is a problem with the LV. Next slide. So the ascending aorta leading to the arch is dilated. So you can see the ascending aorta where it is dilated, arch is dilated, whereas the dilated arch and the descending aorta are normal in size. So you can see the left border in the heart. You can see the aortic knuckle in the left one. So this is the left border, and you can see a blue dotted line in the aortic knuckle. So there it gets dilated. Next slide, please. So ECG, you can see left ventricular hypertrophy with or without strain, and echo is the best one. You can do a transtracheal echo to see it for the accurate assessment of the aortic wall. You can know the number of the aortic wall cuffs, as I said earlier. You can have a congenital bicuspid wall, and also the pattern of thickening of the aortic cusp and the transvalvular gradient to see the pressure gradients, and the left ventricular hypertrophy and the ejection fraction, because here the systolic function is most important. So here there is a problem with the systolic. The diastolic function will be usually normal. So echo is the best accurate assessment for this one. And this is a CT on which you can see the calcified aortic wall. You can see some white patches over there, which shows that there is a calcification in the aortic wall. These whitish things are the calcium deposits. Next one. Next slide, please. So these are all the recommendations, what can be done and what cannot be done. For example, if you see in asymptomatic patients with severe aortic stenosis, the exercise testing is reasonable, because as we all know, it's only an exertional which can be usually seen in the early stages. So it's a grade 2A recommendation. So you can usually do it in the asymptomatic patients to confirm it. It's always an exercise tolerance is the best one. And in symptomatic patients with a severe aortic stenosis and with aortic velocity more than 4, you can actually exercise testing should not be performed, because the patient may suddenly collapse. So you don't do an exercise testing, and usually you do it with your echo. So also never ask for an exercise performance in these patients with a severe aortic stenosis, because they can suddenly collapse. So whenever you are taking for a surgery, always have a good workup, because a patient with aortic stenosis cannot tolerate even a little of hemodynamic compromise. So always try to maintain the hemodynamics of these patients well. Okay, next slide, please. So just go back to the back slide. So when it comes to the management of the aortic stenosis, always remember, see, the management of the aortic stenosis is really critical. See, you don't have a drug, you don't have anything to do medically except only to do surgically. So always remember, for the aortic stenosis, the management is only surgical. There is no role for medical management. And always remember, aortic stenosis is a preload dependent and afterload fixed disease. So you have to give only, you should be very careful with diuretics. For example, if you feel that there is a high BP, and if you want to reduce a PP, and if you put a patient on diuretics, there are more chances that patient can collapse, because it is always a preload dependent. It doesn't depend on reduction of the afterload. So if you have a pulmonary edema patient, for a normal patient with a pulmonary edema, for example, someone lands up in your emergency department with a pulmonary edema, what you do, you initially start nitrotriglyceride, that is your NTG, to reduce the afterload. But here there is no role for the reduction in the afterload. So your NTG doesn't have any role here. Your diuretics, you should be very careful with the diuretics, because if you give more of diuretics, your preload comes down. And if you use beta blockers or calcium channel blockers, again, there are chances that your preload can again come down. So always remember, medical management is really tough in case of aortic stenosis, and the drug of choice for hypertension is usually only nitrotriglyceride, but usually it's always conversely, it can usually, there is no choice for reducing the afterload. So NTG also has not much of role. So always remember, for the aortic stenosis, better to go for surgical repair as early as possible. No medical drug works. There is nothing like this drug will be helpful for aortic stenosis. And if at all the patient is having high BP, to reduce the BP, don't use beta blockers or calcium channel blockers. And AC inhibitors also risky, ARB is also risky. But if there is a chance of very high BP, I mean, only as an hypertensive, you can use AC inhibitors, but never go for any other drugs. Thank you very much.